Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Today we are going to be talking about diseases of the airway, and we'll start off with multifocal non-neoplastic tracheal stenosis. Starting off with relapsing polychondritis. Relapsing polychondritis is a multisystemic disease of unknown etiology, and it's characterized by recurrent inflammation of cartilaginous structures. The nose, the ear, the joints, the larynx, the trachea, the bronchi, all those areas you realize have cartilage in there and they can be affected. Airway involvement is seen in 50% of patients. The larynx and the subglottic trachea are the most common sites of airway involvement. Relapsing polychondritis usually occurs in middle-aged women, and on cross-sectional imaging, we would see smooth tracheal or bronchial wall thickening with sparing of the posterior membranous trachea. We know that the tracheal cartilage is an incomplete ring with no cartilage in the posterior membranous portion. Therefore, it makes sense that we will not have involvement of the posterior membranous portion. There's often increased attenuation of the airway wall, and this may range from subtly increased attenuation to frank calcification. Tracheomalacia, that's expiratory collapse of the trachea, also is commonly present. So in this image, we see a contrast-enhanced CT of the thorax, which demonstrates a segment of narrowing of the thoracic trachea with smooth tracheobronchial thickening. Of course, we can't see the bronchi in this axial slice, but on coronal or on sagittal, we may see that. But this image shows smooth tracheal thickening with narrowing of the trachea. We realize there's enhancement of the anterior portion, and the posterior portion is not as thickened and is not enhancing like the anterior portion. That's the sparing of the posterior tracheobronchial membrane that we're speaking about. So this was a case of relapsing polychondritis. Then we'll talk about tracheobronchopathia osteochondroplastica. That's a mouthful. Tracheobronchopathia osteochondroplastica. This is a benign condition of multiple submucosal osteocartilaginous nodules. Osteo means bone, cartilaginous means cartilage. So you have nodules that are of osteocartilaginous component in the submucosal region, and they are usually along the tracheal walls. And these appear as coarse calcifications with sparing of the posterior membranous trachea. Just like in relapsing polychondritis, this one also spares the posterior membranous trachea because there is no cartilage in that area. So in this image, we see diffuse nodular calcifications in the tracheal anterolateral walls. There is no relevant tracheal stenosis in this case, and the appearance is much more irregular than that seen with normal cartilage calcification. So we can see the posterior membranous trachea here is also spared. This is a case of tracheobronchopathia osteochondroplastica. Now, airway involvement by tuberculosis occurs in a prominent minority of patients with pulmonary TB, most commonly involving the distal trachea and the proximal bronchi. The imaging findings are non-specific. We usually see smooth concentric narrowing of a relatively long airway segment, typically about 3 centimeters or more in length. So these images are cases of tracheal tuberculosis, and in this axial CT, the soft tissue window, we see circumferential tracheal thickening. The coronal curved multiplanary formation shows multifocal tracheal stenosis. Follow the arrows, and left mainstem bronchus stenosis here. These images were obtained approximately 1 month after treatment for active post-primary TB. So you can just see these areas of stenosis, and like I said, it's quite non-specific, so you will be guided by the history that you would be provided. Then in amyloidosis, it also causes irregular narrowing of the airways due to submucosal amyloid deposition. These may be calcified or not. The involvement may be mass-like or segmental. And tracheal amyloidosis is very rare. The posterior membranous trachea is not spared in this case. So in these images, we can see this mass-like thickening and this smooth thickening here, proving to be amyloid deposition, causing some tracheal narrowing. Large airway involvement is seen in approximately 20% of patients with granulomatosis with polyangiitis, most commonly manifesting as subglottic tracheal stenosis with circumferential mucosal thickening. Again, in this case, the posterior membranous trachea is not spared. Calcifications are also not seen in this case. Tracheal involvement by sarcoid is also very rare, and usually it's seen in advanced disease. Tracheal sarcoid has a variable appearance ranging from smooth stenosis to nodular or mass-like appearance, just like in amyloid, just like in granulomatosis with polyangiitis, and just like these two, there's also involvement of the posterior membranous trachea. So to summarize, when we are talking about multifocal or diffuse non-neoplastic tracheal thickening, you could either have those that spare the posterior trachea and those that involve the posterior trachea or cause circumferential thickening. For those sparing the posterior trachea, I think the ones that attack the cartilage, so relapsing polychondritis and tracheobronchopathia osteochondroplastica. This one would appear nodular and with calcified tracheal wall, and this one would cause smooth thickening of the cartilage, may calcify and also enhance, and it also affects other cartilaginous areas, the nose, the ear, the joints, and so on. Therefore, the ones that cause circumferential thickening involving the posterior membranous trachea, you have tuberculosis, you have amyloidosis, you have granulomatosis, polyangiitis, and sarcoidosis, which are all rare, but there. All right, thank you very much for your attention. I hope you are getting value as usual. If you are, give it a thumbs up, like it, share with someone you think would appreciate it. Subscribe if you have not subscribed yet. The next thing we'll talk about are diseases of the large airways, and I will see you then. Thank you very much for your attention.